Our general, please show us a case that's good, bad, and ugly.
Okay, so we'll do an ugly. So an 88-year-old man comes to us with critical AS. He's heart association 3. He's got a mean gradient of 60 millimeters. His STS is 8. You can see hemodynamics here. You can see that he's got a paced rhythm there. So, it seems like a pretty reasonable guy for a TAVR, right? I mean, you don't think we ought to send this guy to surgery. So so we talked about him as a team. We said, yeah, TAVR sounds pretty good to us. This is his CT. So he's got a tri-leaflet, heavily calcified valve. Again, kind of thing that we normally see. It looks pretty straightforward and normal. A lot of calcium, again, that's kind of what we see in these people. And so we decided we're going to put in an S3, and we're taking up nice and slow. One of the real keys on these things is you want to go nice and slow. You don't want to slam it up because you want that calcium to have time to accommodate. And we let it down, and we're going to turn the pacer off, and everything comes back. And while that was so easy, we're almost starting to high-five each other. We're getting ready to take this out. The problem is, this is like less than a minute later. This is what his echo. Can you loop that? Can you play that and loop it? You don't have to loop it much because it kind of looks dead whether it plays or not, right? Is that good or bad?
Ugly.
That's pretty ugly. That's pretty bad. Yeah. What could be wrong with this guy? Well, you know what's wrong with the guy. He's got a bunch of blood around his heart, right? That's a bad thing. So what are our options right now? Some adrenaline? Big shot of adrenaline? Epi? No, that's not gonna help him, right? He's tamponaded.
No, he needs to decompress him.
You could do a little pericardial centesis, but this happened in less than 60 seconds. How fast do you think you can draw blood out? Unless you put like a 25 French. Well, something's bad's happened, right? So, or you could pound on his chest. That's not gonna make any difference because his heart can't fill. His heart's empty. So what do you want to do with this guy? Well, he'll just bleed to death if I do a window by the time I do it. He needs support, right? So we put him on a heart-lung machine. We're all sitting there. So Neal cannulated his artery. So we have a big sheath in. We just take an arterial sheath from the pump, shove it up there. I put a venous sheath in while Neal was doing that. We turned on the pump. So now we're on bypass. Still not great, right? He's an 80-year-old guy. Now he's on bypass. We were trying to avoid that. So you already told me what was wrong. He's got a big tamponade. So it could be an RV pacemaker perforation. Nah, that they don't look like this, right? Could be an LV perforation. They do that. And the ruptures do that. Yep. It could be below the annulus. We saw VSDs. They come to the outside too. It can be intraannular or it can be supraannular. So we have this basic tray that we have ready that we can just open up. The surgeon in our case is already at the table. You don't have to go find the surgeon, and drag him out of his room and say, it's not time to close the groin yet, but please come in. I had Neal there. Neal already knew what to do. Neal had the artery cannulated before I had the vein cannulated. And, we hooked this guy up, and, it was really less than 7 minutes between the time we put the valve in and the time we were on bypass and have this guy fully supported. Because what you really want to do is keep his other organ systems alive so you can figure out what you want to do. And this is what he looks like. Ooh. Is that good or bad?
Ugly. Ugly.
Yeah, that's pretty ugly. This is why we turn the volume down, too, because this usually draws some interesting comments from me. Whereas if I put in the volume later, I can go, oh, look, there is blood coming out of the aorta. We shall all think and fix this now, as opposed to what I really said. So that's not a good thing, right? And you really you're not going to find that hole. So what we're going to have to do is we're basically going to have to stop the heart and stop all the flow through the heart so we can see it. And we do, that's what you see. There's a big hole in the aorta. Now, and what we did was patch the hole with pericardium, put a valve in there, closed it up, 2 days in ICU, home on day 8, went to rehab for a week. He did quite well. If you go back, I don't know if we have, no. Wow. If you can go back and find the original picture and you look at it very carefully, what you'll see is there's a little bit of calcium out by this pigtail. If you watch it, you'll actually see that calcium expand with the valve. Well, if you watch by the pigtail, there's a little piece of calcium there below it, and you'll actually see that piece of calcium, and it shoves out. And when it shoves out, what this was a bicuspid valve with a calcified raphe. That raphe pushed out and up, and it penetrated the aorta just like a knife, and stuck a hole in the aorta. So that's fairly ugly. But I feel bad because I actually didn't put the case out. If I'd known what Neal was going to present, I would have presented a case with 5 valves so I could beat his 3 valves, which I have on my computer if anybody wants to see a case with 5 different valves, 3 S3s, and 2 Evolutes. That's our record. Yes, Steve?
So there's a movement to do TAVR and cath lab, not an
Yeah. So I, you know, what we have a pump up there too, and in theory you could do this, and I get asked to talk about this all the time. You know, where do surgeons fit in the team? And I showed you earlier the continued access from SWVS with 275 patients, 79 years of age, 0 mortality, 0 mortality. People are getting so good that 1 or 2 deaths can move you from an excellent program to an average program, or from an average program to a bad program. I would argue that if you don't have your surgeon at the table with you, whether it's the cath lab or not, but at least at the table with you, if you had to go find me in a room and bring me in, we'd be in trouble. Now you could say, well, we could have cannulated the guy too. You could. I mean, you guys are all very good. But again, I think the thought process works very quickly because, you know, the first thing I think of as a surgeon is let's get on bypass. And we get on there very, very quickly. And then we have time to think about it. Ross?
And a pump team also. There's,
Yep.
There are programs now that have decided to get rid of having the perfusion team upstairs or wherever their case is going on because they think that if the patient needs to be put on pump emergently, they're not going to make it. And so I think it's very important that we have the perfusionist, the pump team there, the surgeon there, and a scrub nurse.
So we believe in checklist, and we do a checklist, you know, early on with our sheaths in to make sure we're ready to kind of move forward. And before we put the valve in, we have a checklist that has 2 pretty important things on it. More than this, it has 5 checklists, but one of them is the anesthesiologist in the room, and is the perfusionist in the room. And we're not going to put the valve in, do the balloon and put the valve in until they're both sitting in the room. So they don't have to be there the whole time, but you know what? When we're going to put the valve in, they need to both be in the room, and this part's over in 10 minutes. You either know you need them or you don't. And once it's in and everything's hunky-dory, which you know pretty quick, then they can go about their business again. But again, we don't want to be running over somewhere and finding a perfusionist or finding an anesthesiologist. And so our checklist includes both those asks: anesthesiologist in the room, perfusionist in the room. Neal.
And so a couple of things. This guy actually was a little fortunate. This guy was actually a little fortunate, to say a little, in that the rupture occurred at the greater curvature where you guys can get to it. Most of these disruptions occur posteriorly where, you know, it's understandably a struggle because you're working behind the heart. The other thing that's interesting is Gus Pichard presented a case like this where the guy had very eccentric calcification. They anticipated that the S3 would rock over as they deployed it. So they did this case under general anesthesia with TEE guidance. They did not ask the anesthesiologist to pull the probe back, and they inflated until the valve started to rock. So they inflated slowly, and as they saw, or as the anesthesiologist saw that the axis was changing, he then said, okay, stop. And so that's where they stopped their deployment and actually got away with it.
Yeah. Well, I mean, I think in retrospect, and there's a whole lot, if I could live my life in retrospect, we'd all be at my ranch in Aspen having a glass of wine because I would be wealthy by now. I would have done things differently. And I think that, you know, this is the first time I recognize that if you look at the CT and you find a bicuspid valve with a long raphe, those raphes really go up a long way and they can become like a knife. And I think that's something that we've all become cognizant of. And, experience comes from bad judgment, and, you know, bad judgment comes from lack of experience. So it becomes a little circle there. So Colin said, don't let this guy talk anymore. Neal, stop him. So that's it. I mean,
Well, thank you. No, that was incredible. Great save. Great save.